So I'm gonna mute myself, and the people are coming in.
Perfect. Thank you. Thank you. Okay, so let's start our webinar. Good morning, everybody, and welcome to this ERKNet webinar. My name is Elena Levtchenko. I'm a pediatric nephrologist working in Amsterdam, and I'm happy to chair this session today. Before starting the webinar, let me remind you that your microphones are tuned off, but that during the webinar, but also after, you can send your questions through the webinar platform. So you have a window where you can write your questions, and I will ask your questions after the presentation. We will try to answer them all. We will have some poll questions, so please be active. The webinar will last about 35 minutes, and we will have about 15 minutes available for questions. The webinar will be recorded, so you can watch it again on the ERKNet platform. So let me introduce the speaker of today. It's Dr. Anne-Els van de Vogt from Nijmegen in the Netherlands. She studied medicine at the Radboud University Medical Centre in Nijmegen. And in September 2022, she defended her PhD thesis entitled Towards Individualized Therapy in Membranous Nephropathy, under the supervision of Professor Jack Wetzels, who is the most renowned expert in membranous nephropathy and many other glomerular diseases in the world. So Anne-Els works as a nephrologist in the Radboud University Medical Centre, where she combines clinical work and ongoing research in the field. And I'm really happy that we see a new generation of nephrologists who take over the clinical care, but also the research from very renowned experts such as Jacques Wetzels and Pierre Roncaud. So this new generation is there, and so Anne-Els, we are very much eager to hear your talk. So please go ahead and start your presentation.
Yes, thank you, Elena. Welcome, everyone. So I will start with membranous nephropathy. Actually is a description of kidney biopsy. So it was first described in 1957 with a characteristical pattern at light microscopy, which showed a thickened GBM. What you also can see is IgG aggregates that are looking like spikes. And here you see immunofluorescence, in which you nicely see IgG aggregations giving a linear pattern here on the microscopy. And in the electron microscopy, you see subepithelial depositions. So at first, this was really a kidney biopsy. We will come to that. Most patients will know that membranous nephropathy is a common cause of nephrotic syndrome in Caucasian adults. We think it's even the most common cause. However, it's mostly known as a nephrotic syndrome, but as you can see nice here in this presentation is that in about 25% of patients, patients present with non-nephrotic proteinuria. Some even have some hematuria, but it's not mostly prominent. And what's important to know is that it's mostly a disease with a preserved renal function. And one of the most common complications is a thromboembolic event, with having a DVT or pulmonary embolism in about 8% of patients, sometimes as first presentation. And in most patients, this event occurs early in disease course, in the first 1 or 2 years' time. So maybe to start with a poll question to know something about our audience. How many patients with membranous nephropathy have you seen? So A, 0, B, 1 or 2, C, 3 to 5, D, 5 to 10, or E, more than 10.
I've started the poll question just to let you know, Anne-Els.
So don't know if everyone was able to answer the question. I'm able to see the question in the poll, but I'm not yet able to see what was voted. So I hope you can help.
Let's just wait another 5 seconds and then I can close it.
Yes. So we have quite many experts in our audience. I see more than 10 of you already saw about, more than 40% already saw more than 10 patients. We have 6 to 10 people who, 10% saw 6 to 10 persons, 21% voted C, 3 to 5 patients, and 19% 1 to 2. So, okay, now we know. We continue presentation. I think.
Is it working?
It's not. I'm not able to go on.
You're not, okay. I have closed the poll question, so normally it should work. Do you want to stop and start your presentation? Oh, no.
I think you're able to see me.
Yes.
Yeah, now the slides are moving. Yeah, please.
Okay. So membranous nephropathy actually is a disease which I always say is a quite a particular immune disease because we know that spontaneous remissions do occur. So here you see our cohort of patients until 2009, about 130 patients. And actually, these were mainly patients with preserved renal function and nephrotic syndrome, apparent proteinuria, and they were followed for about 5 years of time. What you see here in the graph is that about 50% of patients had progression of their disease, which means that they were in need of immunosuppressive therapy because of a severe nephrotic syndrome or because of renal function decline. However, we also had quite a population of about 50% of patients that achieved remission. These were partial remissions occurring even after 2 to 3 years' time. And there was also a considerable amount of complete remissions. So what's important to know is that spontaneous remissions do occur, but can take some time. There was a major breakthrough in 2009 when anti-PLA2R was detected, as you probably all know, which has been described and was detected by a technique of Western blotting. And what was really particular about this is that it was seen in about 70% of patients with idiopathic, or now called primary membranous nephropathy, but it was not found in this original report in patients with secondary membranous nephropathy, other renal diseases, or contour patients. So this took great advantage in the treatment of this disease. And Western blot is difficult and elaborative technique. So suddenly also, especially Euroimmun, developed some assays that we use nowadays. So we have an immunofluorescence test in which PLA2R antigen is transfected into HEX cells, serum of patients is added, and then we are able to have a qualitative signal and to see if these antibodies occur in the serum of the patient. Thereafter, and probably in most hospitals nowadays, we use an ELISA technique. And with an ELISA technique, we are able to quantify titers, which may be very helpful in measuring activity of the disease. And well, actually, a most sensitive assay is a biopsy staining, in which you can see this nice pattern in patients who have PLA2R related disease. And we know that this is most sensitive. So sometimes in patients with low titer, we only have positive biopsy staining and not yet circulating antibodies. So to know is that biopsy is more sensitive to Western blot, and IFT is more sensitive than ELISA. But ELISA has the advantage of providing quantitative levels. And there has been a cutoff, debate of the cutoff, which probably is better 14 than 20. But in practice, I have to say that we mostly see that everything above 2 might have a meaning. So if you're in doubt, then probably you should also use an IFT to be sure if antibodies are gone or if they're present. So actually, if we look to the CADIGO guideline, this biomarker made a big advance in patients with nephrotic syndrome, because we don't need a biopsy in all patients. So obviously, if these antibodies are absent in nephrotic syndrome, you do a biopsy. But if antibodies are present and you have a normal renal function and you are not in need of immunosuppressive therapy, I think you shouldn't do a biopsy. If you consider immunosuppressive therapy, you might consider, but in most cases, I think nowadays people do not perform a kidney biopsy. And if you have an unusual clinical course with a rapid decrease in GFR or serological abnormalities and a suspicion of a systemic autoimmune disease, it might be good to do a biopsy. And also, for instance, if you start with immunosuppressive therapy and you have unexplained decrease in GFR, it might be good to do a biopsy. This actually has been nicely studied by Mayo cohort. We know that these antibodies are very specific from a previous meta-analysis. As I already said, it has a specificity of about 69 to 100% for membranous nephropathy. And in this Mayo Clinic cohort, they studied. So they had 132 PLA2R positive serum tested patients. And they made a distinction between secondary causes like an underlying malignancy or systemic autoimmune diseases. They were excluded. And then they divided patients in a cohort with preserved renal function, so GFR above 60 and GFR below 60. And what they found actually is that in these patients with preserved renal function, they had no relevant biopsy findings. However, in the 37 patients with declined renal function, they find some new biopsy findings like a tubular interstitial necrosis or crescents, which would have consequences for treatment policy. So maybe as a second question to ask you, have you biopsied a patients with anti-PLA2R related membranous nephropathy and preserved renal function in the last years? So answer A, yes, with no additional relevant findings. B, yes, with additional relevant findings. C, no. Or D, I haven't seen a patient with anti-PLA2R antibody related disease. So here comes the question and you can vote. Yes, I'm able to see your answers. Actually, it's quite interesting because A was, 27% did some biopsies and had no additional relevant findings. That's what I would suppose it would be. But we also have like 16% in the audience who had some additional relevant findings. So I think, well, that's also possible. 32% didn't do a biopsy, so according to kidney guideline, to the guideline, and we also have 25% of participants who didn't see a patient with PLA2R antibody-related disease. So I think, well, we probably will also biopsy our patients, but we don't need a biopsy in all patients. Let me check. Yes. So if you look at the guideline, we do a risk evaluation to see which patients are prone or susceptible for spontaneous remissions. And obviously, we have two sides of the spectrum. We have our low-risk patients who are non-nephrotic or have a fast decrease of proteinuria after 6 months of conservative therapy. So these patients are not treated with immunosuppressants. Then we have at the other side, we have very high-risk patients who are patients with life-threatening nephrotic syndrome or rapid deterioration of kidney function in whom immunosuppressive therapy is vastly recommended. And we will get to our treatment options later on in this presentation. Then we have this middle category of moderate and high-risk patients. And actually moderate risk patients are patients with normal GFR, proteinuria of more than 3.5 grams per day, and no decrease of proteinuria of more than 50% after 6 months of conservative therapy, and not having fulfilled high-risk criteria. And these high-risk criteria here are on orange. So that are patients who have decreased renal function or more of 8 grams of proteinuria per day after 6 months. And then you look at what they mean with having other high-risk criteria. So a normal GFR and not more than 50% decrease after 6 months. And what has been then mentioned as high-risk criteria is a serum albumin below 25, urinary markers that are above the cutoff, but also importantly, PLA2R is incorporated into this guideline. So an antibody titer above 50 has been mentioned as a high-risk criterion. And I will show you that I think this is a bit of an opinion and needs some further refinement. So this is a cohort of our center, and what we have seen is a cohort of about 50 patients in whom we did an antibody measurement at baseline. And what you can see is here patients 39 who had progression of their disease, so they were in need of immunosuppressive therapy, and they were compared with patients who eventually developed a remission. And what you can see is that there is a considerable overlap of PLA2R antibody levels at baseline. And I think you probably will need more. You will need more like a sophisticated model, or you need more measurements, but it's difficult to give a one cutoff to say that this is high risk patients. What we do know is that anti-PLA2R is a really good predictive marker. And this is a good example of the Italian cohort of rituximab treated patients. What you see here is patients that have been divided according to their baseline anti-PLA2R level, and they were divided in a lower, middle, and highest tertile. And what you can see is that on the y-axis is a favorable combined endpoint of complete and partial remission, and patients with the lowest antibody level were more prone to develop a remission, and this actually decreased accordingly to the baseline titer. So maybe patients with a higher baseline titer will need more rituximab therapy, or treatment is at least less effective. It's also known that this is an important biomarker at the end of therapy. So this is a small study of our cohort of about 30 patients that were treated for 6 to 12 months with mycophenolate acid and cyclophosphamide. And what you can see is that from the 9 patients who were still anti-PLA2R positive after therapy, none of these patients were still in remission after 2 years. However, if you look at the 24 patients that were negative after therapy, you see that the majority, so 60% of patients, were still in remission after 5 years. So we think anti-PLA2R antibody status at the end of therapy is also a predictor of outcome. So anti-PLA2R antibodies have changed, I think, the field of diagnosis, predicting, and also treatment of membranous nephropathy. And nowadays we are able to test some other antigens and antibodies. I will guide you through this, because here are some of the new antigens. I have 2 slides about the prevalence of these antibodies. We start with the antigens that has been confirmed in other cohorts. And as you can see, these antigens are far less common than PLA2R. So most of these antigens have been described by Dr. Sethi from Mayo Clinic. Also a lot of these antibodies nowadays are only proven with difficult techniques, with mass spectrometry. So hopefully we will get some assays to test this in common practice. Well, most of the important prevalent antigens is NEL1, which is probably prevalent in 10 to 34% of anti-PLA2R antibody negative patients. Second antigen that has been described is THD7A, which have been described by Dr. Thomas, but you already see that this is in only 2 to 5% of patients, which is also about the prevalence of PCSK6 and PCDH7. Exhaustin-1,2 is quite rare in primary membranous nephropathy, but is more often common in membranous lupus nephritis. And the NF has been described, quite rare, about 1% of patients, and this has mainly been confirmed and is associated with syphilis. CMA3B, rare in adults, more common in children, but also in children, as you can see. In a confirmation study, this was only found in 1 of 77 children. And FET1 is quite uniquely after hematological stem cell transplantation and was also confirmed in a small other cohort of these patients. For these other antigens, prevalence is far more rare. TGF-br3 and NCAM1, mostly in patients with membranous lupus nephritis, or contactin-1, which is really associated with inflammatory neuropathies. This is difficult to say in the whole cohort of membranous patients. And then we have HTR1, NETRNG1, and more rare antigens that probably need to be discovered. This is nice how it would look like in your cohort. So this is a presentation of the Mayo again, who have the possibility to test these antigens. So here they started with 270 patients that were tested for PLA2R antibodies in serum and in kidney biopsy. And they tested their cohort, and they saw that about 81% of patients were PLA2R positive in one of these two techniques. So this is really what we also see mostly in other membranous cohorts. And interestingly, most patients had primary disease, but they also found associated disease in 35% of 35 patients, which were mostly malignancies, autoimmune diseases. They tested 6 patients, so 2% of the cohort positive for NEL1, with an associated disease in 5 patients, 2 malignancies, 2 autoimmune diseases, and also a patient with using NSAIDs. So this is what we will see. These patients often have a secondary cause. TSD7-1 was rare, found in 1 patient with an associated malignancy, and exostin-1 was also quite common, but mostly in patients with membranous lupus nephritis. And the other antigens were far less common, and also probably more antigens that have to be detected. So what we learned from these new antigens is that they have a low prevalence, that it's also difficult to assess what's the real prevalence, because in some of these studies it's a bit unclear if associated diseases like, for instance, lupus nephritis is included in the whole cohort if you want to give a prescription of the prevalence. And also it's not always clear if PLA2R, NEL1, TSD7A are in or excluded in prescribing the prevalence of the disease. However, they are quite interesting because some of these antigens and antibodies have an association with underlying diseases. And in this first slide, this is getting more common when I go through these antigens, but in the second slide, you will see that it really gives a hint for an underlying disease. So for PCDH7 and HTR1 and NETRNG1, there are not that many reported, there are no associations identified, but already told you SEMA3B is probably really associated with childhood membranous nephropathy. PLA2R is mostly primary. However, it's associated with chronic viral infections, especially hepatitis B and C, and also with sarcoid. For TSD7A, we know from the publications that we have to search for a malignancy, and it probably might be around 10 to 20% patients. And NEL1, 10 to 35% of cases would be primary, but we have to be aware of a secondary cause, which might be malignancies, but also an associations with lipoic acid or traditional endogenous medicines have been described. So it's really important to ask your patients about these exposures and sites and to see if there is an underlying cause. Then we have these antigens that are strongly associated with lupus membranous nephritis, exostin-1,2, NCAM, TGFR-beta, and NDNF is quite common found in the syphilis population. So in 12 to 20 patients that had syphilis, this antigen was present. PCSK6 is really hinting on the use of NSAIDs. Contactin-1 is an important cause of inflammatory neuropathy. So ask your patients, anti-PLA2R negative, if they have like neurological complaints. And then FAT1 has been described, especially in patients with graft versus host associated membranous nephropathy, but there has also been a report lately that there were 6 patients who had de novo membranous nephropathy after allograft, and then probably there are more antigens that will be described. So if we can use these antigens as we can use PLA2R, I don't know for sure. It will be also difficult because of the cost. But the main lag now is that there is not a commercial test for all these antigens and antibodies present. So as you can see in this table, for exostin-1,2 and TGF-br3, there is not yet a possibility to test antibodies, so they have not been described. And biopsy staining is not so easily done in the antigens in which we see not only a plus, but a plus minus. So what we can test right now is we have commercial assays for PLA2R and TSD7A, although there is only an immunofluorescence test. And for contactin-1, there has been a cell-based assay and an ELISA described, but for the other antigens, it's far more difficult at the moment. So I think they are useful, and for some of them, maybe you have in-house possibilities to stain biopsy. We are able to do an L1 biopsy staining, but if you were to do a biopsy staining for all these antigens, this is obviously time-consuming. So we need quantitative commercial assays, and we also need to validate these results in larger patient cohorts. If we go back to the management of membranous nephropathy, then we know that because spontaneous remissions do occur, we need to wait and see for 6 months if patients have no very high risk profile. And so the essential question is to treat or not to treat. And in the 6 months, we really need to do some lifestyle modifications to give ACE or ARB, and also anticoagulation is an important topic because we know that thromboembolic events can occur. And while considering this, it's important to realize which albumin assay you use into your hospital, because we know that the risk for a thromboembolic event is associated with the height of your serum albumin level. And if this is a small study that we did in our center, and if we would say that the nephrologic assay is the golden standard, you see that if you have the brome-cresol purple assay, which was used in 2 hospitals, it was really correlated and the values were about the same. But what we have seen with another hospital assay, the brome-cresol green assay that were used in the 5 hospitals in the diagram above, you see that about 5 to 8 grams per liter overestimation is occurring in patients with nephrotic syndrome. And this is important because also the GADICO guidelines say something about that. They make a different cutoff. So if you have brome-cresol purple, you can say you do a cutoff of below 20, and brome-cresol green below 25. If patients have values below this level, they have a high risk of a venous thromboembolism. And then for considering anticoagulation, you also might assess bleeding risk, for which you could, for instance, use GN tools. And if you have a low bleeding risk, you should consider to start with anticoagulation, for which you can use warfarin, or you can also use as a similar equivalent low molecular weight heparin with aspirin as prophylaxis. If, however, patients have high bleeding risk, you might suggest or you might consider to use aspirin. If patients have an albumin level between 20 or 30, in the brome-cresol purple assay, you might assess arterial thromboembolic risk. And in most patients, you have then an indication for treating with aspirin. So now let me go to an overview of therapy in membranous nephropathy, because it all started in 1984 with this trial in New England, who really proved that treating with methylprednisolone and chlorambucil was superior above to placebo treatment. So it really proved on hard renal endpoints that it was effective and that it had a high remission rate. So this actually was also the start of the Ponticelli regimen, which was a regimen with cyclophosphamide instead of chlorambucil. So you see that studies here in 1998. What I want to do and to discuss with you is the 4 randomized controlled trials. So we start with Gemritux. I will tell you about the Mentor trial, the Starman, and the Recyclo trial. So here you see to start the Gemritux trial. So here, this was the first randomized controlled trial that evaluated rituximab monotreatment for membranous nephropathy in comparison to NIAT. So NIAT is non-immunosuppressive antiproteinuric therapy. And what was done, these patients were treated for 6 months with conservative therapy. And after 6 months, patients were randomized to continuing conservative therapy, NIAT, or having rituximab, which actually was a low dose of 375 milligrams per meter square 2 times. After 6 months, the amount of remissions was slightly higher in the rituximab arm, however, not significantly. However, at the end of the follow-up, more remissions did occur in the patients with rituximab therapy. So 65% in comparison with 34%. Then there was this Mentor trial. In the Mentor trial, patients were randomized. 65 patients received rituximab, which was dosed as 2 times 1 gram of rituximab. And in these patients, if they had at least 25% of reduction of proteinuria, they were redosed with rituximab 2 grams after 6 months. And these patients were compared with a cyclosporine arm, in which patients were treated for 12 months with cyclosporine, and thereafter this therapy was suddenly discontinued. What they saw is that there was an equal amount of remissions after 12 months, so 60% in the rituximab arm and 52% in the cyclosporine arm. However, after discontinuation of therapy, which you also see in the graphic, is after 24 months, 60% still of patients in the rituximab arm are in remission versus only 20% in the cyclosporine arm. So more sustained remissions with rituximab. Bit difficult in this graphic is that the initial non-response after rituximab treatment was 22%. So actually this 22% of patients were excluded from the study and were not redosed after 6 months with rituximab. So meaning that rituximab therapy is not the option in all rituximab treated patients. So only 78% of patients were still in the trial after the 6 months. Then we have the Starman trial. In the Starman trial, they compared the cyclophosphamide prednisone treatment, which was the traditional Ponticelli treatment with 3 months of cyclophosphamide alternating with steroids, in comparison with patients that were treated with tacrolimus for 6 months. And after 6 months, patients were dosed 1 gram of rituximab, and then tacrolimus was built down in 3 months' time. And what was shown is that the amount of remissions, the primary endpoint after 24 months, was far more common in the Ponticelli regimen arm, so 83% versus 58% in the tacrolimus arm. And it's also interestingly, while looking at immunological response, so this was only in the anti-PLA2R positive patients in this trial. And what you can see is that the amount of immunological remissions was lacking behind in the tacrolimus arm. So only 70% of patients versus 92% after 6 months. But then after rituximab dosing, the amount of immunological remissions was about the same after 12 and also 24 months in both groups. So probably rituximab preserved the remission in this group. And then lastly, the Recyclo trial, which actually was a pilot trial. It was not the amount of patients was actually not enough to have a real randomized trial. So it was a randomized pilot trial. And in these patients also, patients were treated with cyclophosphamide prednisone according to the Ponticelli regimen. And they were compared with patients who had rituximab, but only in a dose of 2 times 1 gram at baseline. And maybe a bit surprisingly, it was shown in this cohort that the amount of remissions was the same in the rituximab and the cyclophosphamide treated cohort, so 51 versus 65% after 6 months, and after 12 months also 62 versus 73% patients. If you then look at this small cohort, so about 37 patients in each group, I think what's remarkable is that although patients were all nephrotic, you can see that they had quite low antibody titers. So in most of the studies, the median anti-PLA2R titer is about 100 to 150 units per ml. So you might question if in this recyclo trial really the high and the very high risk patients were excluded, and this might be an explanation for why no difference was found. So to sum up, I think what you can tell about the new, though they are already maybe a bit old studies, I think that rituximab and cyclo and calcineurin inhibitors induce remission, although not in all patients, so in about 60 to 70% of patients. What we saw in a mentor trial is that rituximab 4 grams is more effective than calcineurin inhibitors. And if you redose with rituximab after 6 to 12 months, you probably have more remissions long lasting. We see that there's a high relapse rate after withdrawal of CNI. And as already said, so rituximab might prevent relapses. So the hard thing about this is that there are no studies with heart renal endpoints other than in cyclophos treated patients, and we have seen that there is a non-response rate in the rituximab treated patients in about 35% of patients. So what happened with adapting this KDIGO guideline in 2021? We already had, I already explained something about risk evaluation. So in the green non-nephrotic patients, you wait and see. In the very high-risk patients, the only therapy that has been tested for heart renal endpoint is cyclophosphamide and steroids. And in the other two categories, you are able to choose. If patients have moderate risk, you can also choose to wait and see, or you give rituximab or calcineurin inhibitor, for instance. And if patients have high risk, you can choose between rituximab or cyclophosphamide or calcineurin inhibitor. So then we come to our third poll question. Do you use oral cyclophosphamide in your patients with membranous nephropathy in your practice? A, yes, I consider this in high and very high risk patients. B, yes, I consider this in high and very high risk patients, but only with IV treatment. No, I consider this therapy too toxic. Or D, no, I haven't prescribed immunosuppressive therapy in patients with membranous nephropathy. Okay, I'm able to see your answers, and I see that majority of people have A, 43%. Yes, I consider this in high and very high risk patients. There are also quite a few of you, 22%, who consider this, but then with the cyclophosphamide IV. 1/3 of patients consider this therapy too toxic, and 5% of patients, people haven't prescribed immunosuppressive meds in these patients. Okay. And we continue. Yes, so I think where we need to go to is that we are more able to use PLA2R antibodies, and perhaps in the future also maybe more other antibodies to really guide our therapy. And maybe we can also use this for evaluating new therapy options. So I want to show you this study that we've done in Nijmegen. So we have treated our high-risk patients with this modified cyclophosphamide therapy regimen. And what we did in the Netherlands, we used not the Ponticelli regimen, but we used continuously cyclophosphamide orally, 1.5 milligrams per kilograms per day, together with steroids, methylprednisolone, and then prednisone 0.5 milligrams per kilogram every other day. And instead of treating all patients 24 weeks, we evaluated patients after 8, 16, and 24 weeks for the occurrence of PLA2R antibodies. And if anti-PLA2R antibodies were negative in the immunofluorescence test after 8 weeks, we discontinued cyclophosphamide and we built down prednisolone. We had the same evaluation after 16 and 24 weeks, and only in the case of persisting antibodies after 24 weeks, we considered additional immunosuppressive therapy, but then with a mycophenolate because of the cumulative maximal dosage of cyclophosphamide. And what we actually saw in this study is that in already 70% of patients, PLA2R antibodies disappeared after 8 weeks of therapy. Another 10 patients, antibodies disappeared after 16 weeks. And if patients were still positive after 24 weeks, they also were thereafter. So there were 8 patients that were considered for additional therapy. Actually, we saw that 40% of patients had a very nice results with need of only 8 weeks of cyclophosphamide after a median duration of almost 5 years. The patients who needed longer duration also had a remission without the need of additional therapy. And we saw that all the patients had a very good outcome. So 92% of our patient population was in remission at the end of follow-up. However, as you can see, there were 10 patients who had a remission and relapse according to the follow-up duration of 3 to 5 years. And we also had a group of patients who became anti-PLA2R negative, but had a very fast relapse of their antibodies and needed additional therapy. So we were studying if we can predict which people have a nice response. So people in group A were the patients who were only in need of 8 weeks of cyclophosphamide. B had a short remission, but were in need of additional therapy. And C needed a longer course of 16 or 24 more weeks of therapy. And this is actually quite interesting because we had a small group of patients in group A who had a PLA2R titer below 80. And these patients were really remarkable because we think this is predictive that these patients already have remission for a short duration of therapy. Now, while this is a small group, obviously we need to confirm, but probably you can use baseline titer to guide your therapy duration and to also see on the forehand how long your therapy would probably be needed. Well, to show you this is an interesting study of the group of Sunosi. This is a potential new therapy regimen. However, this is a very intense treatment protocol because in this study, patients were treated with 8 grams of rituximab in 2 years' time. They were treated with cyclophosphamide orally for 8 weeks, and they also had quite some steroids. But what you can see is that with this potential new therapy regimen, you have partial remission rates of about 100%, and probably membranous nephropathy is a good treatable disease if you use enough immunosuppressive therapy. However, we want to individualize therapy, well, we did this pilot trial and used a modified regimen from the Sunosi regimen, and we used 2 grams of rituximab, 8 weeks of cyclophosphamide, and 3 weeks of steroids in 26 patients. And what you also saw in our patients is that this was very effective with high immunological remission rates of about 90% already after 8 weeks. And we found out that patients who started with a high PLA2R antibody titer, they almost 5 of the 9 patients in this baseline titer they were in need for extra therapy, and we were already able to identify them after 2 or 4 weeks. So probably this is also a nice option, and if we use PLA2R, we are able to predict which patients will benefit from this therapy. So maybe if we are going to draft new guidelines, we might do an additional risk evaluation and to see how we can use PLA2R to evaluate therapy. So I think the first question is immunosuppressive therapy advised, or you have to do a risk classification? And then the second question is an early response needed? If not, probably you can use rituximab. If yes, I think there's still a place for having treatment with cyclophosphamide and steroids, but then maybe having a short course or having a modified therapy regimen with rituximab. And then we have the remarks, the question marks. So from Mentor, you would say all patients with a PLA2R level below 200 probably have enough with rituximab 2 grams. However, if this titer is higher or PLA2R body antibodies are negative, you might consider the therapy with cyclophosphamide, or maybe we have additional therapy options in the future. So in these patients, maybe we have to redose rituximab. There are reports that are there that some patients might have underdosing if they are severely nephrotic, so they just need more rituximab. Or we know that some patients develop anti-rituximab antibodies, and in that case, there is a new anti-CD90 treatment coming, obinutuzumab. We have some very nice results in retrospective cohort studies, and probably there might also be a place for newer treatments with anti-plasma cell therapy or combinations with anti-BAF or anti-APRIL. So just to give you some information about the obinutuzumab. So obinutuzumab is a fully humanized anti-CD20 monoclonal antibody, and it has a very high efficacy. And this is a cohort in a study of the CJSON of last year. And what you see here is 42 rituximab treated patients versus 21 obinutuzumab treated patients. And you see that after 1 year, more than 90%, so actually 20 of the 21 patients had a partial remission, which is significantly higher than in comparison with rituximab treated patients, and also far more complete remissions do occur. So it gives a more effective B-cell depletion, and also the side effects seem to be acceptable. So with that, I come to the conclusion of my presentation. So I think what I've tried to tell you is that the detection of PLA2R antibodies is important for diagnosis and also for guiding therapy. It's also a predictor of therapy for rituximab, but also for cyclophosphamide. And I think maybe because PLA2R antibody might be an earlier indicator of response than proteinuria, we might also use this to evaluate new treatment options like obinutuzumab, anti-BAF, anti-APRIL. And there is a need for developing quantitative and commercial assays also for the newer antigens and antibodies. And we might see how we can use this in patient cohorts. So with that, I want to give you a hint for the next webinars that are to come. And I hope you enjoyed our presentation, and I hope there are some questions that I can answer for you.
Thank you very much, Anna-Els. It was a very, very nice presentation, very comprehensive, a lot of new ideas, and I recognize in the style of your mentor, Jack Wetzels, with a very clear approach to the patients, differentiated, individualized. So really great pleasure to listen to your talk. So we have quite a lot of questions. I'll try a little bit to group them. As usual, we have a lot of questions about the treatments. So one maybe simple question: are steroids always necessary when cyclophosphamide is used?
Yeah, actually, I think steroids are necessary, and obviously the side effects of therapy are with the cyclophosphamide and prednisone are particularly common with longer therapy duration use, but there are not real studies about using cyclophosphamide monotherapy, so I would not recommend to do so. However, as I said, the pilot trial that I showed you, we only used like 3 weeks of prednisolone, and this is a really well tolerated regimen. So I think if you treat for with cyclophosphamide and steroids, you should use the steroids at least for 8 weeks, as we are used to do, but maybe we are able to shorten prednisolone duration if we use more combined schedules or regimens.
Okay, very clear. So there is a question regarding new antigen and special treatments. So Dr. Kopic is asking whether there are special suggestions for treatments and it's discontinuation in patients with semaphorin 3B positive membranous nephropathy.
Well, that's difficult. From the new antigens that have been described, there is some information about THD7A, that there is also a relation with clinical course. So if these antibodies disappear, that also proteinuria disappears, but we have no proof for these very rare antigens. And also it's difficult to test, but I think it's not a weird idea to think that if you're able to test these antibodies, maybe we can use them in the same way that we use PLA2R. But then, yeah, there has to be like maybe a multiplex assay in which we are able to test several antibodies together to spare costs. But for now, it's a bit too early to say we can already use it and test this.
Actually, this doctor clarifies now that then the question is for a child that achieved remission with cyclosporin, I think, and maintained it on tacrolimus for 2 years. So maybe you have suggestions on discontinuation of the treatment.
Okay, yeah, I think for what we know about CNI or tacrolimus is that if you give it for 1 year and you quit, then you have many relapses. There are some studies from Asia that if you, what we are used to do is that the 2nd year we build down the CNI. And I think if you do a longer therapy duration and you build down for a 2nd year, you have less relapses. So it's not then what we saw in Mentor, that you already have only 20% of patients that's still in remission after 2 years. So that might be a suggestion if you want to build down a calcineurin inhibitor.
Yeah, thank you. So another question is, how extensive is your workup, or how extensive workup do you recommend for malignancy in patients with NEL1-associated membranous nephropathy, especially if it is asymptomatic and immunosuppressive therapy is planned?
Yeah. Well, as I showed, we think that most of these patients have a secondary cause. However, my experience is that you will not always find. So I think what's important, especially in an L1 membranous nephropathy, and I don't know if the majority of people are already able to test, but in our lab, we do a biopsy staining, so then we know. I think important to have like 6 months of conservative therapy and also to see if nothing really develops. But I think we have to ask patients for NSAIDs, to ask if they use any skin creams, to see if they are not using any homeopathic or Ayurvedic medication. And then probably in the older population, we also have to be a bit more aware of having an underlying malignancy. So I would be more eager. I think we all do an X-ray of the chest in all the patients, but if they have like abdominal pain, maybe you should make a scan to see if there's something. I think if you are able to wait, you also have some time to see if there are not alarm symptoms coming, but there are also more primary NEL1 membranous nephropathy. So also here, indeed, sometimes you have to use immunosuppressive therapy if you have not an underlying secondary cause. And if you have an underlying secondary cause and you obviously are able to get rid of this factor, you then should first wait and see if spontaneous remission then occurs.
Thank you. Thank you very much. And by the way, several people thank you for the brilliant presentation, which is very nice. So we have some very active pediatric nephrologists in the audience. So Dr. Elisa Manieri asks you, again, thanking you for the presentation. And this is also a specific question about the child with a medium risk membranous nephropathy, mildly positive title of PLA to R, and nephrotic range proteinuria. After how many months of tacrolimus can you say that it's not working?
Well, that's a good question.
So I think the child for 6 months.
Yeah.
I think, and the question is whether you should add a different drug like rituximab, or what would you do after 6 months not responding?
Yeah, so I have to be honest, I haven't seen many children, and it's obviously a rare disease in children, but what we do in adults is here that if it's a PLA2R positive patient, and after 6 months you don't get rid of the PLA2R antibodies, we give rituximab. So I think that's, then we decide this won't work. And you can have then, for instance, a Starman-like regimen. So then you can give 1 gram of rituximab and build down the tacrolimus in 3 months' time. It's a bit more difficult if your patient is not PLA2R positive, because then obviously you don't have a biomarker that you can check after 6 months to know something about the efficacy of therapy. Then I would say if there is no improvement of your nephrotic syndrome, and after 6 months you still have serum albumin below 30 or proteinuria of more than 1 to 2 grams, I would consider to switch to rituximab.
Okay, and I have a question from your mentor, Jack Wetzels. So that's a good discussion you can do online. Is initial remission a good outcome parameter? Should we better focus on persistence of remission and define the loss of the autoimmune response? Can you follow the question? So whether the remission is as such is a good outcome, or should we better focus on the persistence of remission?
Yeah. Well, I think for now we know that it's important to if you have antibodies and you are able to measure them, we know that it's important to attain for immunological remission. But as I've showed you in our antibody-guided therapy trial, we saw that only measuring PLA2R is not enough because we know relapses do occur. However, for instance, with therapy with cyclophosphamide, you might think that if you have a relapse and you are able to treat it again with a shorter therapy duration, that's not a real problem. But in the end, we need better biomarkers to see who's the one who has a persisting remission and who's the one who will have relapse, and are we able to predict? Well, that's right now difficult. So I think we have not, maybe we are able to measure other factors from the immune system. And in the ideal situation, obviously you would have a persisting remission, but I don't know if this maybe answers the question.
Probably Jacques is not able to say something. I'm sure he had a lot of comments, also maybe to the other questions, but you are muted, Jacques. So if you want to comment, please write and I will read it for the audience.
Sorry to interrupt you, Elena, but we are running like 2 minutes, but then I think the webinar ends, so we should come to an end.
Yes, we do. I think there are still some questions, and I think many people thank you again, and I'm sorry for those whose questions are not answered. So thank you very much, Anna Els, for their very nice presentation. Thank you, the audience, for your very active participation. The webinar will close. Thank you.
Thank you, everyone. Thank you to Elena and Els. Thank you. Bye-bye.
Bye.